Hi, my name is Dr. Marysia Tweet. I'm a cardiologist at Mayo Clinic in Rochester, Minnesota. And it is my pleasure to introduce to you today Dr. Margaret Long. This is for the interview of the experts, Women, the Intersection of Cardiovascular Disease and Female Reproductive Health podcast. And today's topic is contraception decision making for premenopausal women with cardiovascular disease. Dr. Long is our guest. She is an associate professor of obstetrics and gynecology. She also has a joint appointment with the Department of Pediatrics here at Mayo Clinic in Rochester, Minnesota. She is also a very active clinical investigator with a focus on treating complex patients from an obstetrics gynecology perspective, and that includes HPV, contraception, complex pregnancy, and so forth. And on top of that, she has been working here as a colleague at Mayo Clinic. Now, I think this is her 30th year. So,
Yeah.
congratulations. And you have a lot of knowledge and expertise to share with us
Mhm.
today. So, I really appreciate you being here today with me.
Great. Thank you. Thank you for having me.
Correct. Okay, great. So, maybe just to start off, I work in our women's heart clinic quite a bit,
hmm
and I will sometimes see young women, premenopausal women who I'm counseling them against pregnancy or they don't desire any future pregnancies.
hmm
And, the question I have for you is how should I approach my thought process, or how do you approach if I refer
hmm
someone to you contraception in patients with cardiac disease?
Um, One of the first questions is kind of what is her goals as far as pregnancy? Is she never wanting to get pregnant? Is she wanting to get pregnant in the next year? If she says she wants to get pregnant in the next year, then it's time to start planning and referring to maternal fetal medicine and, collaborating with the cardiovascular team. But if not, then we start looking at, what options might be appropriate. Some of that has to do with medical acceptability as far as, complications, but it also has to do with other issues that they might have as far as do they have heavy menstrual bleeding? Do they have menstrual related symptoms, either cardiovascular or other?
Can you describe to me, are there some contraception options that are safer than others for patients with cardiovascular disease? And are they just as effective?
Yeah. So the contraceptives that are associated with the highest risk of complications in regards to cardiovascular disease are contraceptives that have estrogen in them, which at this time is many of the contraceptive pills, the contraceptive patches, and the contraceptive ring. Another contraceptive that it's really useful for some people, but is not my favorite for a lot of patients is the injectable contraceptive, just because it's a very high dose of hormone.
Mhm. Okay. How about, I feel like as a cardiologist, I've had a fair number of patients with that IUD. Do you mind
Right.
mentioning anything about the IUDs as well and risk in that regard and efficacy?
Okay. So intrauterine contraceptives, also known as IUDs, are very effective. They actually work about as well as tubal sterilizations or vasectomy. They do not require major surgery. Depending on which one it is chosen, they can last anywhere from 3 years. The most common one lasts for 8 years. There's one that lasts for 10 years. So you get very long acting contraception. It is reversible, however. So if somebody wishes to get pregnant in the future, once it comes out, it quits working really fast. So it's not a permanent option, but it is also a really good option for people that don't ever wish to become pregnant. They can use the hormonal contraceptive. It also is really good about decreasing menstrual blood loss. And for patients that have to be on anticoagulation, this can be a real improvement in their quality of life.
Mhm. Can you go a little more into detail about patients who require anticoagulation? So let's say
Mhm.
they're on that for a valve or some other cardiac history. How do you approach those patients, or do you approach them any differently?
In general, we don't put people on estrogen containing contraceptives if they're on a medication if they require medication for anticoagulation. Um, so that's the main thing. Um, Intrauterine contraceptives are an excellent choice. The contraceptive implant can be a reasonable option also. It's not as reliable as far as bleeding. Some people don't have much bleeding on it and they really love it. Other people can have irregular spotting and bleeding, are not big fans.
So, what are on the market right now? And just if you don't mind naming some
Yeah,
examples, because a lot of cardiologists like me are not familiar with all the different
right,
names.
right.
What would be examples of that for?
So the intrauterine contraceptive that we use the most is called Mirena, which has 52 milligrams of levonorgestrel in it. So it's a progestin-only contraception. There's another brand called Laletta that is basically the same thing. There is Kylena, which is a lower dose IUD. It has 19 and a half milligrams in it. It has about half the daily levonorgestrel that Mirena has. That one is good for 5 years.
Mhm.
And then, so those are the hormonal contraceptives IUDs that are used the most. There's also a copper IUD, which is called Paragard, and that one will last for up to 10 years.
Okay, very helpful. And then you were mentioning injectables too. Can you explain
So
that?
the injectable contraceptive that's on the market right now is medroxyprogesterone acetate, or Depo-Provera, and it is very effective as long as the injections are given in a timely fashion. It's the making sure they get given in a timely fashion that's important as far as efficacy. As far as reversibility, it varies a lot from person to person. That the time that they start ovulating after their last injection can be days. It can also be months to like a year plus. So it's a lot less predictable. It's also a lot more progestin than you get exposed to with any of the other contraceptives. And there's a recent black box warning out about possible meningioma
Sure.
with long-term use.
Okay. Um, do any specific contraceptive options affect cardiovascular risk in regards to things like blood pressure, cholesterol? I know we had touched very briefly upon like the clotting aspects, but
Right.
do you mind going into those potential side effects that
Yeah.
cardiologists should be aware of? Or if I have a young woman who's
Mhm.
on contraception and she has a heart attack and I see her in the hospital,
Right.
what should I be thinking about?
Yeah. So I'm going to address the second part first.
Got
As
it.
far as you have a young woman in the hospital with heart attack, in general, we do not continue estrogen containing contraceptives because they do increase the risk of clotting. The doses of estrogen in oral contraceptives have steadily gone down since their initial release. At one point in time, there were some that had 100 micrograms of ethinyl estradiol in it, and now we're running 35, 30, 20. There's even some that have 10 micrograms. So the amount of estrogen is a lot less, but because it's oral, you get the first pass effect, and so it can increase coagulation. So generally, if they're on an estrogen containing contraceptive, you would want to stop that. However, having this patient get pregnant very shortly after a cardiac event is quite,
Yeah.
there's a potential for danger there. And so definitely don't assume that your patient will not be having sex. That yeah, sometimes people are like, oh, well, they just had a heart attack, of course they're not going to have sex. No, it's not. Yeah, don't make that assumption that as soon as they stop their pill patch or ring, it's going to stop working right away. And that impress upon them the importance of having some sort of contraception before they resume relations, because my guess is that the recommendation for pregnancy is going to be later if you know if there's
Correct.
a recommendation for that.
Yes, and sometimes it depends on what is going on. We're tailoring it
Right,
to the patient, but it can be anywhere between wait at least a year to we would
right,
recommend that you do not become pregnant in the future, or if you do, you'd want a whole pregnancy heart team
right.
guiding you through that. So then a follow up to that are, and we again we did touch upon this a little bit, but maybe just driving home the point of what options are available to that particular patient. So let's say we
Right.
stop her contraception or oral contraception that contains a lot of
Yeah.
estrogen.
Right.
What would be the next steps, like in the hospital, even, or
So,
what would we have to make sure so we don't drop the ball on it?
yeah. So, options that a cardiologist could start for a patient uh, would be the progestin-only pills. These are easy to start. They are safe. There's virtually no contraindications to it. Might be like breast cancer. Um, but other than that, there are virtually no contraindications to them. The first one is norethindrone, which is a progestin-only pill. As I mentioned, it is a prescription. It is very finicky. You have to take it at the same time every day. You have like a 2-hour window of time to take it. Another option is the norgestrel pill, which is called the O pill. This is an over-the-counter option. Um, Also, very low dose, virtually no contraindications. Would be something that the patient could start themselves. The third progestin-only pill that's on the U.S. market is the drospirenone, which is the brand name is Slind. It is a higher dose of progestin than the other progestin-only pills. There's a little bit of concern about drospirenone off and on about whether it's thrombogenic or not. That probably wouldn't be my first choice. I would definitely recommend these as a bridging option. It might be what they would choose long term, but because of the lower efficacy of them, that you might not necessarily want to say, start this and then see you. That it's something that let's start this now. Let's get you set up with a gynecologist or your primary care doctor to talk about, longer term options.
Excellent advice. That is very helpful. Any other important lessons or things that I should know as a cardiologist?
So obviously, we're aware that there are some cardiac conditions that increase the risk of complications during pregnancy. And in virtually every situation, that there is a form of contraception that is effective and is safer than pregnancy. So sometimes in the past, people have looked at articles on contraceptives and they're like, oh, they're dangerous, but they're dangerous compared to never getting pregnant, which I guess possibly by abstinence versus, using the contraceptives. So,
That's very helpful. So, in other words, don't be afraid to talk to patients about this. Make sure that they're aware, make sure they are plugged into all the resources. And then
right.
you provided some helpful information in regards to safety and medication choices for our patients.
Yeah.
So,
Yeah.
I greatly appreciate it. I hope you don't mind if I reach out to you
Okay.
with future
Great.
questions
Okay.
of mutual
Great.
patients. And
Yes.
I
That'd
hope
be
you
perfect.
and our listeners have a wonderful day. Thank
Okay.
you.
Great. Thank you.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Rajiv Gulati, Chair of the Division of Interventional Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducation.mayo.edu and explore our live and online programs, our quick on-demand modules, and our CME accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.